Good morning, everyone, and welcome to today's session of COVID Community of Practice, Changing the Way We Work. I hope that everybody had a wonderful summer, and congratulations on getting to the end of the first week of September with all its new routines. Sometimes it can be a challenge. I'm Eleanor, Colledge. I'm a family physician. I work in East Toronto. I'm also the CPD Program Director for the Department of Family and Community Medicine at the University of Toronto. I'm delighted that we can continue to bring these sessions to you together with the Ontario College of Family Physicians, and really excited about today's set of panelists and the conversations that we'll be having. I'm going to turn things over now to Dr. Mekalai Kumanan, our OCFP president, to introduce the session.
Morning, everyone. I hope you're having a great start to September. It's so nice to be here with all of you, and I'm also really excited about today's session. We've got some great topics that we're covering. I'd like to take a moment to thank our speakers for being here with us. And just a reminder for all of you that this is a Maine Pro accredited session, and details will follow the session. Next slide, please. Okay, so moving on to our land acknowledgement, we acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite us all to reflect on the territories we are calling in from as we commit to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And I'm calling in from Kitchener, the lands traditionally used by the Haudenosaunee, the Anishinaabe, and the Chinantan peoples.
Thanks, Mekalai, and I'm calling in from Toronto, the lands traditionally used by the Anishinaabe, the Haudenosaunee, the Chippewa, and the Mississaugas of the Credit. And in reflecting today, I came across the fact that the CMA is actually issuing a formal apology about the role doctors have played in harming members of Canada's Indigenous communities. And I thought I'd bring this to everybody's attention, in part because you may want to watch it when it's live streamed on September 18th. And it looks like there will be some really interesting presentations, including from the gentleman shown in this photo here, who many of you may recognize as Dr. Lafontaine. He was past CMA president and the first Indigenous president of that organization. And I mean, it's wonderful to have these formal apologies, but of course, action speaks words as well. And one of the reasons they said they're putting out this apology is to encourage medical professionals to think about their own reconciliation journey. And as I was thinking about my own, which of course I'm still on, one of the things I've really loved in my practice is being able to have what I think are more open and productive conversations with patients of mine that have Indigenous background. But as somebody who really loves reading, I'm actually looking forward to, over the fall, delving into many of the Indigenous authors that are now published within Canada and learning more about their communities through some of the fictional work that's out there. So encourage others to think about what they might be doing next in their own journey. Next slide, please. So just a reminder that this session is part of a series, all of which are available online. And always a big thank you to the group behind the OCFP, the DFCM that put it together. Next slide, please. So very excited today. We have 3 panelists, so it is going to be a pretty jam-packed session, but I think a really helpful one as well. At this point, I'm going to turn things over to each speaker to introduce themselves, starting with Dr. Darrell Tan.
Okay, thanks so much, Eleanor. My name is Dr. Darrell Tan. I'm an infectious diseases physician at St. Michael's Hospital and a clinician-scientist here. In terms of conflicts of interest, my institution has received some support from Gilead for investigator-initiated research and from GlaxoSmithKline for participation in industry-sponsored clinical trials. Those are all related to my work in the field of HIV, as opposed to what I'll be speaking about today. Thanks.
Thanks very much, Darrell. And Dr. Dan Warshafsky.
Hi, morning, everybody. Daniel Warshafsky. I'm one of the Associate Chief Medical Officers of Health for Ontario and continue to have nothing to declare. These slides regularly.
Great, thank you. And turning things over now to Dr. Chase McMurren.
Tansei, good morning. I'm Chase McMurren. I'm a family physician with focused practice in psychotherapy primarily. I'm also the Indigenous Health Theme Lead in the MD program at the University of Toronto. I've received stipends and honoraria for teaching and committee work. Glad to be here.
Thanks very much, Chase. And Dr. Kumanan?
Thank you. My name is Mekalai Kumanan. I'm a family physician in Cambridge, and I'm currently serving as the OCFP president. I do receive a stipend for that role, and it does not pose a conflict for today.
Thanks, Mekalai. And I've already introduced myself in terms of conflicts of interest, nothing that poses anything for today. I do receive a stipend from the OCFP and also for some work I do for McMaster. Next slide, please. So just a reminder, if anybody's new to this forum, that if you want to participate in terms of asking questions, which of course we encourage, please pop them in the Q&A. And if you see a question there that you would like answered, then please upvote it, because I will be prioritizing those that have upvotes as the questions that I asked first. Also, love to have people share their resources, reactions in the chat section. So certainly use that for networking. Next slide, please. Okay, I think at this point, I'll just give you a heads up about how we're running the session. So we'll be hearing from Dr. Tan, who's going to be speaking about Mpox. Then we'll take a brief break for questions, and then move on to Dan, who's going to be covering more preparation for the fall and what's upcoming. We'll have some more questions then, and then turn things over to Chase, who will be speaking about how to manage some of the boundaries that we have with patients in our practice. We aim to finish all of the main content by 9, giving ourselves a little leeway. If we have extra questions that we want to cover between 9 and 9:15, we will do that. Okay, thanks very much. We'll turn things over to Dr. Tan.
Okay, thank you so much for the introduction, Eleanor. I'm going to speak for the next just a few minutes about what's the latest with Mpox. And on the next slide, I wanted to just thank again Mekalai for the nice Indigenous land acknowledgement. This is just a depiction of the horrific effects of what colonization has done to Indigenous people, and I wanted to link it to today's presentation because what's being depicted here is actually early colonists intentionally using the virus smallpox, which is very closely related virologically to our topic today, Mpox, as an agent of biowarfare explicitly. And the harms of that continue to be felt today. And the parallel, even if perhaps somewhat less clinically severe, harms that are done to another vulnerable group, specifically sexual minority men, is really what we've been seeing as a major impact of Mpox. So on the next slide, I'm about to show you some images that are fairly graphic. I'm going to use this to illustrate what the usual clinical course is when someone contracts this infection. So as we've said, it was primarily being transmitted. It has primarily been transmitted in our geographic setting among networks of gay, bisexual, and other men with sex with men, or GBM, who have new partners or are somehow linked newly to a sexual network where it is being transmitted. And that means that the first anatomic location at which we have typically seen lesions are those where it is first inoculated. So you see it in the mouth, on the genitalia, in the perianal area. You can also have lesions that are deep to what we can visually see on these images, so in the throat, inside the rectum, and those may present simply as pharyngitis, proctitis. People may mistake that for another benign condition, hemorrhoids, something like that, in the absence of visual symptoms initially. When lesions do appear, or if they appear, they typically evolve a little bit over time. They may start as a papule. People might think it's a bump, a pimple, something like that. And then it rapidly evolves into a pustule that then ulcerates. And in that, in all these images, you're seeing a very classic depiction of what the classic Mpox lesions look like. You see this central depression that's dark. People describe it as, I had a black dot in the middle of the lesion. That's very much what we see with Mpox. And if you see this, it has a high likelihood of being Mpox, although of course there's a differential diagnosis. On the next slide, you'll see what tends to evolve after that. So people can then develop, or perhaps coincident with that initial phase, constitutional symptoms, flu-like symptoms, fever, chills, myalgia, headache, and the rest of it. But then they may also start to develop skin lesions elsewhere on the body. And what's challenging about those lesions is that they may not have that characteristic appearance that we just looked at. Instead, you may have something like a macule on the left, or a small papule. You may have a classic looking vesicle, such as the image in the middle, or you may have a pustule on the right. Interestingly, these were all captured on the same person at roughly the same time. So it can be a little tricky, and many patients will say that, oh no, that's just an ingrown hair. That's just a pimple. I get those all the time. And while that may be true, when I've asked them, oh, can you humor me and let me swab it for Mpox? Indeed, very often it is Mpox, in fact, as opposed to the thing that they thought it was. So it does mean we have to be very, very vigilant in looking out for how this infection can present. Now, further complicating things, on the next slide, you're going to see that in the context of vaccination, which we'll speak about in just a moment, once again, we can see that people can become infected. It's not 100% protective, but what we typically see is a milder phenotype. And so here are some images of a person who had just received a dose of vaccine and then acquired Mpox, and you can see that the lesions are really subtle, and you can really understand how a person might brush them off as something completely benign. Again, these lesions at this stage that's being shown in these photographs swabbed positive for Mpox. The way to make the diagnosis is to use one of these viral swabs that you're seeing on the right-hand side of the slide. This is the same sort of vial with universal transport medium that we use for viral testing. So the same thing you would use for HSV, VZV, influenza, COVID, what have you. And remember that you can send a specimen from multiple sites that you think might be involved. So perhaps from an obvious skin lesion, but perhaps from the throat, from the rectum, if people complain of a tickle in the throat or pain in the rectum, that might correlate with where they've been exposed. Okay, on the next slide, I want to emphasize that unfortunately, this is getting to be a trickier and trickier infection in many ways, because we have been seeing what's probably a lot of asymptomatic or perhaps posse-symptomatic, minimally symptomatic transmission. And that's been well described in the literature, as you can see here. It likely explains why we see these waves of infection without the Mpox completely going away from the population. Unfortunately, this is probably here to stay. It's probably already become endemic within sexual networks. And it's important to remember that someone not having symptoms or not clearly remembering having these rip-roaring lesions does not mean that they did not have it. We can clearly identify clinically chains of transmission that involve people who had minimal symptoms. So on the next slide, that begs the question, well, what can we do about it? First of all, of course, you're going to try to have a high index of suspicion and then diagnose it using a viral swab. In terms of management, unfortunately, there is not much. There is a lot of supportive care, of course, that we're going to emphasize. There is an antiviral drug called tecovirimat, or TPOXX, that many people have used for this infection, depicted here. I won't go into the mechanism of action in any detail. Importantly, though, I want to emphasize that to date, we do not have any clinical evidence that demonstrates clearly whether this drug has clear efficacy or not. This is a self-limited infection that will improve over time, even if we do nothing in the vast, vast majority of people. So we cannot know for sure whether this is making a difference or not. In a very severe case where we're kind of trying to do anything we can because of severity, it is reasonable to request access to it through the Special Access Program, which is administered actually through Daniel's office at the Provincial Ministry of Health. And you can contact that email address there at the top, and updated guidance on this will be posted from the provincial office, I think as soon as next week. But on the next slide, I want to emphasize that because of that uncertainty about the role of this drug, around the world, clinical trials are ongoing, including right here in Ontario. In Ontario, there are 2 sites that are enrolling in Toronto, at the Toronto General Hospital and at St. Mike's, which is where the vast, vast majority of cases in this province have been seen. It's called Platinum Can. We're linked to other trials around the world. There's a long URL there in the middle of the slide, but perhaps it'll be easier if you happen to have someone that might be eligible for this to just Google Mpox and then CTN, that's the Canadian HIV Trials Network, where the research network that's running the trial, or any combination of words to try to get at Mpox clinical trial here in Canada, here in Toronto, and this will pop up. In order to qualify, people do not need to have microbiologically confirmed infection yet, because that would introduce a delay. So if someone has very obvious Mpox infection, they would be eligible for the trial. that's what we have to offer in terms of management. And the next slide, of course, the last thing that we can talk about is what we can do to prevent. And beyond behavior change, trying to minimize contacts, awareness, there is, of course, a vaccine. It's a modified Vaccinia Ankara Bavarian Nordic, or MVA-BN smallpox vaccine originally. It's also known by the trade name Imvamune in Canada. It has different names in other countries. And what I'm showing here is a summary of results from a number of studies that have looked at vaccine effectiveness around the world. It's a 2-dose vaccine series administered at least 28 days apart, but when it was initially deployed in 2022 going forward, only first doses were made available initially. So we have a lot of studies that have looked at the effectiveness, including 2 that were done in Canada, giving us fairly similar estimates of how much it decreases the risk of an infection. 1 dose, roughly 60-ish%, perhaps a little more if people have gotten that second dose. And so we do think that it is valuable. It does prevent infection. It does attenuate the severity of infection if people are unfortunate enough to acquire it, but it is not foolproof as is the case for so many vaccines. In the next slide, you can see that NACI has issued some guidance that was updated in 2024 about how to use this vaccine. It can be used in a post-exposure prophylaxis or PEP setting if someone's been recently exposed but does not have any manifestations of Mpox yet, ideally within the first 4 days, not beyond 14. But the main way in which we're using it is as a pre-exposure prophylaxis or PrEP sort of intervention. And the criteria for using it are listed at the bottom of this slide. I won't read them out in detail, but what you can see by scanning it is that it is really related to a very clear link to a sexual network. Now, this does not have to be necessarily ascertained by the clinician or the person administering the vaccine. We do that to minimize stigma and the requirement that people disclose very personal information when they may not feel comfortable doing so. But really, it's about GBM, sexual partners, sex workers, folks who work in sex on-premises venues, and those who engage in sex tourism. Key messages on the next slide are that the guidance tells us there's no need to give 3rd doses at this time. There's no need to consider prior history of smallpox vaccination from the 1960s or 70s or whatever. There is no role for vaccination of healthcare workers. That's really important as long as we're using standard precautions, gloves, gowns. That is not thought to be a major mode of transmission. We have not seen infection in healthcare workers globally. There's no need to space it out from other vaccines. And importantly, in the context of all of the media surrounding what's happening in Africa and elsewhere, there is no need for a travel-based vaccine at this time, with the rare exception of someone who's explicitly going somewhere for sex tourism. That might be something to consider. That's not very common. And again, we would not recommend the vaccine at this time for someone who's simply going to visit friends and relatives or just going on vacation somewhere. So key points are summarized on the last slide. In terms of recognition, this is what classic Mpox looks like. Again, that central depression, but remember that the appearance can be variable, that there may be pharyngeal or rectal symptoms as the only manifestation, and that there's a lot of mild or even asymptomatic infection that's possible. To diagnose it, use a viral swab, not a bacterial swab. To treat, unfortunately, it's mostly supportive care. We don't know whether this tecovirimat works or not. I really encourage people to contact the trial if they think they have someone who might be eligible. Just Google Mpox in the CTN, Canadian TB Trials Network, or in severe cases, you can email to access the drug through the Special Access Program. And then in terms of prevention, it's this 2-dose vaccine series. It is available through public health units. I saw the question asking about how difficult it is to reach right now, and I think it's simply because many of the public health units have been overwhelmed in the context of all the media interest, but that is the way to access it. There are rare other clinics that do a lot of sexual health care or HIV care that have access as well, but primarily it's through your public health unit. The eligibility is based on sexual networks, and it's not recommended at this time for healthcare workers or based on travel. So I'll leave it at that. Happy to answer questions. Thanks so much.
Great. Thanks so much, Darrell, for updating us on both how to pick it up clinically and also how to treat and vaccinate for it. A couple of questions that have come up actually just around the testing part of it. Some questions around, first of all, can you use the same viral swab to test for Mpox, HSV, varicella on one lesion, or should a separate second swab be submitted for Mpox specifically?
Yeah, excellent question. You can use the same one, excuse me. just write it all onto the requisition. The lab will sequentially test. They'll start with Mpox once they've extracted the material for PCR testing, because that's the most concerning for infection control purposes. And then subsequently, they'll go on to do the other viruses if that's in the differential. So yes, you can use the same swab. Thanks.
Great. And also similarly, when you're swabbing for Mpox, do you have to unroof the lesions? And Laura was wondering, did I hear that we dump out the liquid medium in the transport vial?
Great questions again. So the dumping out of the liquid medium is no longer required. That was very, very, very initial guidance, but no, don't need to do that. In terms of unroofing the lesion, excellent question. Certainly, if one unroofs a lesion and gets more fluid, more purulent material, that is going to increase the diagnostic yield. However, after a number of cases were seen in people who had a needle stick injury, the guidance was modified to not require that in order to minimize the risk to healthcare workers. So if you've got a really kind of juicy lesion there, you could probably just kind of manually unroof it a little bit or poke at it really hard with that swab stick, and that would be adequate to get some fluid, kind of getting any moist material that's on an active lesion. That would be helpful. You could also try to use it to dislodge even a tiny forming scab and to try to reach the material that's underneath a tiny early scab. That could increase the diagnostic yield. And generally, if you've got a juicy enough or a moist enough lesion that you're even considering unroofing it, probably it's not required, but do be very vigorous in collecting your sample. And remember that you can collect more than one from different anatomic locations to increase the diagnostic yield.
Great, thanks for clarifying that in terms of the testing. And actually along the lines of transmission, there was a question regarding, can Mpox be transmitted by aerosol or airborne? And what PPE would you recommend?
Yeah, that's another great question. It was an area of controversy earlier because, of course, the related virus smallpox could be, and therefore it was thought previously that Mpox did have some component of aerosol or airborne transmission. However, since the 2022 outbreak, which has, proliferated, we have like over 100,000 cases, tons of experience globally now with this infection. It really, really does not appear to be the case that there is airborne transmission. There was a systematic review recently published, I think, out of Hamilton at McMaster, kind of looking at the handful of studies that have formally studied this, and it concluded that there is no evidence for that. And so I think a lot of IPAC guidance from different places may or may not have fully caught up to that. It was initially very, very conservative, saying maybe it is, so let's tell people to use those precautions. But the emerging evidence is that it's really clearly not an important mode of transmission. So the fundamentals are really just the universal precautions that you're going to use in anyone who has a funny looking lesion like this. So gloving is probably of course, the bare minimum that you would use. In our hospital settings, there is still a recommendation to gown and to mask and to face shield even. But again, I truly think that is more than is necessary. And I think guidance will evolve to catch up with what we're seeing on the ground.
Great, thanks for clarifying just what we've learned now over time. In terms of it being more prevalent, one of the questions that also came up is Mpox now very prevalent in the heterosexual community as well?
Great question. The answer to this time is no in Canada, as is the case in most industrialized world settings. Now, this is where it really becomes important for us to continue to be vigilant and watch the emerging epidemiology. Of course, that's been all over the news. And of course, it's hindered by the fact that the surveillance systems in much of Africa where this is occurring and changing are so limited, and that's a huge attention is needed to the global inequities that explain that. So we actually don't have quite enough information about what's happening all over the world, but clearly in our setting, overwhelmingly, we continue to see it in GBM. Now, have there been any cases in heterosexual people? Yes, there have. A very, very small number of women who have acquired it from male partners, but this is not at all, a widespread heterosexually transmitted infection at this time, and so that's the reason for which the guidance on vaccination continues to focus for now on the groups that we mentioned.
Great. And in terms of vaccinations, a couple of questions about that. So can the vaccine be given after infection?
It's not recommended in that setting. It's one of those situations where we believe that the natural immunity that is afforded by having the real deal is important at providing some protection. Now, that's not the same thing as saying that it's impossible to acquire an infection after a prior infection or after prior vaccination. That has been reported in the literature, but clearly it remains somewhat exceptional to have a second infection, certainly. We're again going to have to very carefully watch the incidence of infection in people who have had a single or 2 doses of the vaccine to see whether there is a point in the future at which it seems to be enough of a problem that we're going to go ahead and recommend more interventions such as a booster dose. But at this time, that is not the guidance. But again, it continues to evolve.
Okay, so along that line of revaccination, or whether that will ever be required, can you just clarify our knowledge, at least to this point, of how long the vaccine remains effective for?
Yeah, it's such a great question. And it's one of those situations, just like we remember from the early days of COVID, that, our experience is only as long as, time only moves in one direction. We have literally only got just over 2 years of experience with this. So beyond that, we simply do not and cannot possibly know. Again, we just need to continue to be vigilant and watch this. And NACI, for instance, is obviously watching this issue very closely and does plan to issue updated guidance as needed.
Right. So of course, we have to wait and see what happens over time. And just one last question before we move on to Dan, and we'll come back to some further questions after Dan's talk. Are there any long-term consequences? And actually, this speaks to the fact it's only been around perhaps for the last couple of years in terms of knowledge, but there was a question about whether there are any long-term consequences of Mpox infection, disfiguring scars or worse, cancers after 20 years. So wondering what your thoughts are on that.
For sure. Certainly the scars are something that people are sometimes troubled by. It varies from person to person, just, what typically happens with that person with scarring. So we do see some hyperpigmentation that is bothersome to some people, but of course not harmful in our experience here in Canada and elsewhere in the industrialized world. Now, it's not quite true to say that there is no experience with Mpox beyond 2022, because of course this was an infection that was re-emerging in Central and Western Africa for decades, and the inattention to that issue as a global health issue is a large part of why we've had this global pandemic. It's a reminder of how important it is to be interested in the issues that affect humans anywhere on the planet, because it's one world. In terms of other long-term consequences that we've seen in that setting, there again is not much, unless someone has had one of these very, very rare cases in which there's end organ involvement. There have been very, very rare cases of encephalitis, for example, some of which have been fatal, particularly in severely immunocompromised people. Extremely advanced AIDS has been a reason that someone has actually gone on to get a serious complication like that and even die from it. Extraordinarily rare in our setting, certainly not recorded yet in Canada, but we need to remain vigilant. In general, no long-term consequences for most of what we're seeing.
Okay, well, that's certainly reassuring to hear. Thanks very much, Dr. Tan. We're going to turn things over now to Dan, Dr. Warshafsky, to speak about some of the other things that are coming our way this fall.
Great. Thanks, Eleanor. I'll go fast. I still see there's like 1,000 questions in the question box. So just want to first give a quick update on what we're seeing from our respiratory metrics right now and what we've been seeing in the Southern Hemisphere. So at this point in time in Ontario and mostly across Canada, Northern Hemisphere, flu and RSV are still remaining quite low. So you can see sorry for so many things on one single slide, but you can see in the top, middle, and right is our flu and RSV percent positivity. They're still quite low. And then similarly for the hospitalization, you can see still remaining extremely low at this point in time. COVID is obviously a little bit different than that. So what we've been seeing so far for COVID is about an 18% positivity at this point. So it has been increasing since around late July and then stabilized at this point for a few weeks now. So what we're seeing is basically a moderate level of COVID that's continuing to be transmitted right now. You can see, below the percent positivity one, we have the COVID outbreaks, and then below that is COVID hospital cases. Hospitalizations and outbreaks are still much lower at this point than we see normally during the peak of the respiratory season, but certainly have been increasing in the last few weeks. So we are getting started with our respiratory season now, and COVID has been for the last several years, starting earlier than for flu, RSV, and other typical respiratory viruses. In terms of the Southern Hemisphere, what they saw for the respiratory season, number one was a fairly heavy flu year. It was an H3N2 dominated year. So we get data from, Australia, South America. It was H3N2 dominant. So that usually means a little bit more severity that we see in seniors. And that was reflected in the hospitalizations they saw in the Southern Hemisphere. Additionally, they also saw a not insignificant portion of H1N1, which really means that we saw a very elongated flu season. So we didn't have an enormous flu peak in the Southern Hemisphere. It was basically a fairly steady for several months, more than we see in other years. Similarly for COVID, there was no kind of big peak that they saw for the respiratory season. It was a long and steady season, so we're expecting fairly similar Ontario. So essentially, probably a heavier season than last year overall, if you're looking at the total numbers, but hopefully, based on what we saw in the Southern Hemisphere, we won't be seeing a significant peak in the same way. So if we're looking at our hospitalization data, hopefully we shouldn't see that significant limitation, and it'll be a little more spread out, which may mean more people overall that are hospitalized, but we won't necessarily see the same compromise in hospital system capacity. For RSV, obviously, we'll have new products this year that I'll get to more, and hopefully we'll see a much better season than last season for RSV. So I'll jump to the next slide. So for a COVID program, so we're still awaiting the newest product to come in. Health Canada had directed all provinces and territories to start withdrawing our XBB products. The XBB is now very out of date, quite frankly. If you look at like the genetic charts, XBB and the currently circulating K strains are very, very far apart. So, the effectiveness is somewhat in question about using it anyways, but we've been directed by Health Canada to withdraw those products so they can make the switch over to the new KP2. So KP2 is one of the more dominant strains. It is starting to switch over to KS now, but still very similar to the current strains. And so we're expecting much better effectiveness. Ideally, the timing of that product should align with our flu rollout. So we're expecting to have both flu and COVID vaccines probably arriving around the end of September. Again, those initial rollouts always go first to long-term care homes and hospitals for those highest risk populations, with then opening up in October more broadly to high-risk individuals. And then for flu, of course, we open up in November for the general population. COVID, depending on how quickly that KP2 supply comes in, we'd see it open more broadly sooner than flu potentially. But just again, it's a timing of supply coming in. But again, we should have the new product for KP2 for COVID coming starting late in September. Next slide. So RSV, just a quick reminder of what we have in place. So one is for our older adult program. It's being slightly expanded this year beyond last year's. So it's still for individuals 60 and older, with the addition this year of all retirement home residents. So it includes long-term care home, elder care lodges, retirement homes, the whole long list, and you see below of some of the other high-risk populations. And so that is publicly funded and available for anybody in that situation. A reminder for RSV, it's not a yearly vaccine. So the NACI statement came out. We have very clear data that we see effectiveness at least through 2 seasons, potentially 3. We're still following, but at least through 2 seasons. So it's not something that if your patients did receive it last year, whether through the publicly funded program or on the private market, they shouldn't need another dose of RSV this year. Next slide. So our infant program, and this is the big new change, obviously, that we have from last year that I've spoken about previously. Again, the main difference this year is the Beyfortus product. So instead of Synagis going to a very small number of high-risk infants, maybe 3,000 a year is what we saw previously, we are going to have an all-infant program for Beyfortus. So it's a very effective monoclonal antibody, very effective in reducing hospitalization and medically attended LRTI from RSV. If you look at the data that Canadian Immunization Guide is quoting, it says 80% effective at reducing medically attended RSV-related visits. So that's really, really quite good. The dosing is everybody under the age of 12 months old, so under 1, is going to be eligible this year. And everybody from 12 months to 24 months who is high risk, with those same high-risk criteria many of you are probably familiar with from Synagis, can get as well. The dosing is essentially by age and weight, as you have here. We do also have the maternal vaccine that's available for pregnant individuals. So Brisvo can be given to pregnant individuals from 32 to 36 weeks gestation. It really is not the preferred product. The effectiveness, if we're looking at CIG, is probably about 30% lower than Beyfortus at just any medically attended RSV infection, so certainly not as good. And the recommendation is really for Beyfortus for the infant. But if you do have patients who are absolutely going to refuse Beyfortus for their infant, then Abrysvo would be an option to use instead. Next slide. As a reminder for who's giving it and where, so every infant who's born during the season, we're expecting to have the Beyfortus product arriving around mid-October. So probably starting mid to late October, every birth in hospital will be offered a Beyfortus for them to have. And hopefully it's going to be administered in hospital for discharge, which is wonderful. It will be added to the yellow card probably in like November, so not quite for October, but you can still write it in on the yellow card, and so that should be taken out if you're going for hospital. It'll be on discharge summaries, so primary care providers should be able to identify that for patients. For any of those infants born either outside of a hospital setting or prior to the season starting where we have product, it would be asking people to go to their primary care provider in order to get that administered. Public health will be administering it, variable around the province depending on what they do, but more of a supportive role, particularly for more vulnerable populations that don't necessarily have access to primary care. And for those especially high-risk second season infants, a lot of them are currently connected through the RSV networks to pediatric specialists, and they'd be going through the same kind of processes they've gone through in previous seasons. Next slide. So a quick reminder again of the changes to our publicly funded pneumococcal program. It is simpler now than it was before without the multiple products needed different age groups. Essentially, for any of your low-risk infants, so kids under 4 who don't have a high-risk medical condition, they get the PCV15 product, and everybody else gets the PCV20, whether they're high-risk infants, high-risk adults, older adults over 65 that are low risk, it's PCV20 for everyone in that population. So that's been available now since the end of July, and so hopefully everybody's getting familiar with using those newer products. Next slide. I wanted to give a quick update on pertussis because we're seeing quite an increase this year in Canada. Quebec has reported more than 13,000 cases of pertussis this year, which is a huge increase from what they've seen previously with 90 hospitalizations. And in Quebec, it's predominantly been infants younger than 3 months that are a majority of the cases. If we can go to the next slide, please. Just to show what we're seeing in Ontario. Oh, I didn't realize I had animations. So you can see the very, very last line is what we're seeing in 2024 right now. So we are having quite a significant season of pertussis as well. We do regularly see basically ebbs and flows in how much pertussis is spreading. So you can see here, 2012, for example, was also a year we had significant number of cases in the thousands of cases. And so it's something that we do expect to have higher years and lower years. This year has been especially high and looking to be, probably fairly similar to 2012 in terms of the number of cases we're seeing compared to other seasons. If we can go to the next slide, please. So where are we seeing the increase? Infants remain the highest risk if we're just talking about the rate in the group of under 1, again, particularly under those 3 months. Again, they predominantly, if you're under 3 months, many haven't necessarily even received their first vaccine for protection. So we often see the highest rates there. But you can see this year, our rates are actually similar to our pre-pandemic rates in terms of the rate per population in that age group. What we're seeing this year predominantly is a huge increase in the 10 to 14 age range, especially, but basically from in kids and teens from basically 5 to 20, we're seeing an increase in rates. So this is due to a few factors. Number one, we normally see relatively high numbers of cases in some of these groups, particularly the 10 to 14 who might have been a little bit late in getting their Tdap booster at that age. And we do see waning, so it's not unsurprising to see this. We also know that particularly for that kind of 10 to 20 age group, many individuals still weren't kind of caught up with their Tdap vaccines from just limited access during COVID. And so our coverage rates in that population remains lower. So really, this is a big reminder that if you have any kids in that age range, just ensure they're coming in getting their Tdap vaccines. Next slide, please. Just a reminder of the schedule. So the ones where we're seeing, the 2, 4, 6, and 18 months, we still see really excellent coverage. That's less of an issue in terms of the kids of that age getting their vaccines. Where we see it start to drop off in terms of coverage is beginning a bit at the 4-year mark, but really, again, it's that 14-year dose that often is missed or delayed. And so that's really why we're generally seeing the increase in pertussis in that age group. And then always a reminder for in pregnancy, every single pregnancy, it's recommended. And that's, again, of course, to protect those newborn infants who won't be getting their vaccines until 2 months and limited in that under 3 month, basically, cohort that we're seeing. Next slide, please. Oh, great. That was the last one.
Great, thanks so much, Dan. And I'm glad it was the last slide because there's a lot of questions building up in the Q&A, so want to get to those. And we'll try to sort of give you them in certain areas. I think the first question and I think you answered this in a written form, but also wanted to just bring it up, is just the question about rat testing. Where is it going to be available? Will it be available? Yeah, anyway, how are we going to access it if we need it? Will it be available in emergency departments? Whatever you can tell us about that.
Yeah, so it will be available this season. It's going to be a bit narrower than previous seasons. It's not going to be at every health unit or grocery store or that sort of thing. It's really going to be much more focused on available for patients who are eligible for treatment. You know, I mentioned in one of the responses, you know, if it's a person who's not eligible for treatment, younger, healthier, the message should just be stay home while you're sick, whether it's COVID or flu or RSV or whatever other respiratory thing. It doesn't particularly matter. Just stay home when you're sick. Avoid high-risk populations if you're someone who's sick right now. If they are eligible for treatment, that's where we need the testing to make sure they can get the right treatment. If they're positive for COVID, they can get then one of the COVID antivirals, either Paxlovid or remdesivir. Not positive for COVID and we're in flu season, they might be eligible to then get also Tamiflu or Tamiflu for flu. But it's really focused on treatment. So it'll be available to, you know, primary care providers, it'll be available at pharmacies. Emergency departments, you know, some have rapid PCRs in some of the emergency departments, or even some primary care providers do. So, you know, they may be using that instead of a rat, but they will be available to have testing in those centers where people needing treatment will be coming.
Okay, so just to be clear, so pharmacies hopefully will have them. We should be able to still order them for our clinics and then some emergency departments. Is that right?
Yep. Yeah. So more details to come on how you're going to be ordering them in pharmacies. Again, for pharmacy, it depends really on the pharmacy and what they want to offer. Yes, absolutely. There are rats available to purchase in pharmacies, like they're stocked on the shelf still. But in terms of having it administered through a publicly funded program, for example, that's going to be pharmacy dependent if those pharmacists are comfortable doing so.
Okay, thanks very much. And then a couple of questions just around the COVID vaccine. And I think you did answer this. One was somebody was asking when will the updated vaccine be available? And I think you said hopefully along the same lines as when the flu is coming out, flu vaccine.
Yeah, both flu and COVID we should be getting late September. And so more broadly available kind of for those highest populations in early October, ideally.
And there is still no combined product, correct?
Not yet, but we're getting closer. The last I saw looks like maybe 2026. We might have something available, but certainly not this season, unfortunately.
All right. And in terms of treatment, because of the change in who receives Paxlovid, there was a question about a senior with COVID was told that Paxlovid is no longer being given, and has that changed and why? So perhaps just clarifying what are the indications for treatment at this point.
Yeah, and I'd refer people to the Ontario Health guidance for treatment. So the age was modified slightly and gone up a bit. So basically anyone 65 or older is someone who's still recommended. Outside of that age range, it would then be dependent on medical conditions that you might have, either immunocompromised being the #1 thing. And then they list out a whole bunch of other medical conditions that can be considered for individuals who are older and potentially might meet treatment. So the ODB like limited use codes align with those criteria. Basically, it's are you 65 and older? Are you immunocompromised? Or do you have a medical condition? So I would just, if any concerns you have, I would just review that Ontario Health guidance in terms of exactly who might be recommended.
Okay, thanks very much. In terms of vaccines, there's a question, can you confirm that we'll no longer have access to Novavax? And if so, who do we direct our advocacy to make it available?
Yeah, Novavax, it doesn't look like we'll be having it this year in Ontario or in Canada. Novavax, the uptake is actually like extremely low. What we definitely hear is a very vocal minority. Last season we gave like 5,000 doses of Novavax out, which is very, very tiny for a population of 16 million in Ontario. So yes, there are people who should be getting that instead and prefer that product. It doesn't look like this season it will be available in Ontario, but we should hopefully have it again next year.
Okay, thanks for clarifying that. A question, and actually this could go to you or Darrell, just as a question around masking in hospitals. The question is in the Q&A. I won't read the entire question because it's quite long, but just in the last part of it is, in reality, masking in hospitals is becoming rare, even in areas such as oncology. And this person is wondering, will we be bringing back this effective tool given the number of hospitalizations for COVID this year?
Yeah, and love if Darrell wants to comment too. So in terms of a provincial mandate around masking in hospitals, that won't and can't happen anymore, frankly. We're not in an emergent situation. We don't have the powers provincially to mandate masking across hospitals. They're independent organizations that can make their own IPAC recommendations. Would I strongly recommend that people working in hospitals and patient-facing areas in the height of the respiratory season mask? Absolutely, I would. And so it'll be up to each hospital to put their policy in place, but it makes a lot of sense to be doing so. So Darrell, I don't know if there's anything else you want to say about that.
I would echo what you just said. It's an institution by institution decision, and certainly, our institution here, I can only speak for it, St. Michael's Hospital. Our policy is that it is certainly not required, but certainly strongly recommended, and specifically in units where we know that people are at increased risk of COVID and severe outcomes, such as oncology, other immunocompromising conditions. So absolutely, I think that there's a sensitivity to that, and that might change. Of course, the IPAC representatives of all of our major hospitals get together on a bi-weekly call in Ontario. People may or may not know that, and they discuss issues exactly like this. And it's around this time of year that they may very much be looking at this issue again, I think.
Okay, thanks for going over that. And actually, another question, which Darrell, I might get you to jump into if appropriate, is just given the lack of testing that we're doing now, how accurate are some of the COVID statistics that we're getting? I guess, how comfortable can we feel if we're not testing as much, knowing how much is happening?
We're still testing every hospitalized patient with appropriate symptoms, right? So we have an extremely accurate view of hospitalizations related to COVID, ICU admissions related to COVID. We have our percent positivity based on what proportion of tests are positive. So we have a very good sense of what the overall burden is based on those metrics. We also follow how much Paxlovid and remdesivir is being prescribed. So even though we don't get the results from every single rat test, we do have a good sense of, in the population that's not being hospitalized, what's the burden that we're seeing based on antiviral usage. So I think our COVID metrics are, are we getting every single case and being able to show that? No. Are we certainly getting a good understanding of the trends and the overall severity of COVID from the metrics we have? Absolutely, yes. Darrell's nodding, so okay, good.
Great, Darrell's nodding. Thanks for that. All right, in interest of time, I'm going to jump us into some RSV questions. So first of all, really quick and easy question: can you give RSV at the same time as Prevnar 20?
Yeah, really good question. So there isn't any direct data on RSV being co-administered with pneumococcal at this point in time. There's lots of data about being administered at the same time as other seasonal vaccines like flu or COVID. The NACI recommendations are very clear that you can be co-administered with seasonal vaccines. Realistically, it's probably fine to co-administer with pneumococcal, Shingrix, and other non-seasonal vaccines. But the Ontario guidance will be updated shortly to have some clarity on exactly what that is. There wouldn't be a concern for safety. It's really about monitoring side effects in that one, because we don't necessarily have the same data as we do with those seasonal vaccines. So if it's the best thing to do is give it co-administered with some at the same time, then please do. And there'll be a little bit more coming soon on whether there should be a window at all.
Great. And in terms of a couple of other questions with the change in the access to the RSV vaccine in retirement homes, is this something that retirement homes are going to be responsible for administering, or would it be the primary care provider?
It's going to be a mix. So in many regions, public health units are supporting retirement homes to administer in the homes themselves. If the homes, many homes have deals with or partnerships with pharmacies where pharmacists will come in and administer. So that's something that can potentially be leveraged as well. But, if a retirement home resident is coming to see their primary care provider, obviously most retirement home residents are much more mobile than long-term care home residents. Absolutely can be given through your primary care clinic as well. And so primary care providers, you can all order through your local public health unit to have supply on hand for those patients. So it'll be a little bit of a mix depending on the region.
Okay, and actually, I think you've answered another question, which was how do we access the RSV vaccine? Clinician was trying to access it for a homeless elderly patient and wasn't able to, but you're saying we should be able to do it through our public health?
Yes, yeah. If it should be available very shortly through public health. The supply, kind of came in August and started to go to long-term care homes predominantly, but there should be more supply now, so it should be accessible in your regions.
And what if somebody wants to access and pay for it privately? Can they buy it? And is one better, Arexvy versus the more recent one?
Yeah, Arexvy and Abrysvo are both on the private market, so patients can buy them if they wish to. We haven't really seen a significant difference in effectiveness, so either product would be reasonable to use, whichever is more easily accessible.
Okay, and on a very practical note, how do we prepare the infant vaccine in terms of administration?
The Beyfortus product?
Yeah.
So it's very easy. It comes in a pre-filled syringe. So all you have to do is put your needle on and then you can give it. It's much easier than the adult vaccines, which require reconstitution.
Wonderful. Nice to hear that's going to be easy for us to do if we're doing it in the office. Along the lines of treatment with Beyfortus, a question about will Abrysvo be covered by public health if a pregnant woman wants it and doesn't want to give Beyfortus to their newborn?
Yes, so it is covered. It's publicly funded for pregnant individuals who don't want to have Beyfortus for their newborn. Again, I would just counsel them on it because it is significantly less effective than Beyfortus. So Beyfortus is the preferred product if it's something they're willing to get. But yes, it would be covered if not.
Okay, and my understanding though is if the if a pregnant patient gets Abrysvo during pregnancy, is their infant still going to get Beyfortus, or are they no longer eligible for it?
So if they are high risk with those conditions, like, congenital heart disease, respiratory illness, then they could still get both products, and that is the NACI recommendation. If not, then no, they shouldn't be getting Beyfortus if the mother or parent already got Abrysvo. Do we have tracking that will be known necessarily if it happened? Realistically, no, unfortunately. But it's something that we shouldn't be doing. And again, we need to marshal our resources to make sure we can get the most number of people access. And so if Abrysvo was administered, you don't need to or shouldn't be administering Beyfortus unless they're very high risk.
Great, thanks very much, Dan. At this point, I'm just going to turn things over and we'll come back to you with some more questions if we have time at the end. But I'm going to turn things over to Dr. Kumanan just to briefly speak to a policy agenda, and then we'll be going on to Chase.
Thanks. I just wanted to shift gears for a moment and encourage all of you to provide input into the OCFP's policy solutions. We know it's a really challenging time in healthcare and has been for quite some time. So we are building out our policy solutions and really want to make sure that they are reflective of your needs as family doctors. It would be incredibly helpful to hear from as many of you as possible across the province. So if you've not done so yet, the survey is fairly brief. I'd really appreciate if you could take a few minutes to fill it out before September 13th. And the link for this survey also went out in my August presence message, and I think it's just been popped into the chat.
Great, thanks very much, Dr. Kumanan. And now very happy to turn things over to Dr. McMurren for a little bit of a change of pace in terms of management of patients in the office.
Yeah, great. Thank you so much. And I'm awed by all of the questions and the reality of practice and how many hiccups can be kind of in the process of something that ought to feel straightforward. Or at least it seems straightforward when a patient asks for it. And so really just wanting to name the complexity of the work that we do. This morning so far, we're talking specifically about specific infectious conditions. And that's like barely a drop in the bucket relative to the many other things that show up in primary care practice. So wanting to acknowledge that and hoping to be brief here. Really with the idea of acknowledging and celebrating the fact that each of us are doing the best we can. And for many, our best never feels quite good enough to ourselves or to the people that we're trying to serve. So wanting to name that and also acknowledge that the system itself is a huge contributor, right? And so noticing in the chat the mismatch between sort of what's expected to be happening and then what's happening locally And then the challenge of trying to reach the pharmacist if we do call in, or whether the fax machine is working. There are just so many factors that we really can't even begin to try to manage ourselves. And so wanting to name that, that managing is pretty exhausting. So perhaps even thinking about shifting the language from managing patient expectations to acknowledging them and letting them be what they are without feeling like we need to figure it all out ourselves. So the main takeaway I wanted to highlight was that the how matters. The what definitely matters. So the dose and the timing, et cetera, the what piece is important, though the how really matters as well. And how we navigate situations, how we move through conversations with folks when they're irritated or we can't offer what they're hoping for example. The how can shift the process significantly. And so I just wanted to highlight that we have a lot of power and ability if we're aware that how we're doing something makes the difference. And so noticing if we're frazzled or we are really hungry, angry, exhausted, if we can be aware of that, then we can decide how to proceed in a bit more of a purposeful way. So next slide. I'm thinking about the how. I'm also thinking about Velcro and Teflon. So we have nervous systems like many of our other animal neighbors, and we look for threat. Our nervous system, it seems to be set to look for trouble to keep us away from death. That can translate, though, in us noticing everything that isn't going well, or feedback that is not friendly, and forgetting the rest. And so I wanted to highlight this concept of Velcro and Teflon, that, again, often the good things sort of slip off the pan like Teflon, the Teflon pan, whereas the moments where people are exasperated or feel really disappointed, or we feel really annoyed that things aren't coming together, that those moments stick like Velcro. And at the end of the day, sort of the irritation and the challenging moments stick more than the delightful ones. And so an invitation to notice when things do go smoothly, or people are appreciative, or we have moments of joy, as a practice, because if we don't do it purposefully, it often doesn't happen. And some research shows that we need to sort of experience that positive or enjoyable feeling for about 15 seconds for it to get registered by our nervous system, unlike the challenging moments, which we sniff before we even sort of notice them, because our sense of smell is the first to detect any kind of threat. So just wanted to highlight this idea that Freud noticed that threats to our self-esteem or self-conception can cause more anxiety and distress than threats to physical well-being. So the idea that if we really want to be an effective physician, and it's not happening because we can't get through to public health or can't get the vaccines and what, that can really cause overwhelm in our nervous system. So next slide. Almost done here. I really like alphabet mnemonics, and so the ABCDs can be helpful for me anyway. So the first is to acknowledge. So if someone is asking for something that doesn't make any sense or is totally unreasonable, for example, I find it helpful to acknowledge my frustration to myself, at least, to be like, this is not the way I want this to be going. The next is to breathe. And so if nothing else from today, I know it seems obvious to and kind of dismissive even sometimes when we're invited to breathe. The breathing is really powerful. It's certainly as powerful as psychedelics when we look at holotropic breath work, for example. So breath is a strong medicine that can help us through moments. And so I often find it helpful to breathe before speaking, that there's time to breathe and sort of reset before doing anything else. And then the C is to consider the complexity that's there, the fact that the person is trying their best to get their needs met, and then also thinking about like what's possible in that moment. So if we had a bit more time, we could unpack this alphabet starting place. But for now, I think this idea of acknowledging the impossibility of a situation when we're running an hour behind and we're trying to get through to the pharmacy, that like this is hard. Breathing before we do anything else, considering the complexity. And then the D for do is like, what would I like to do in this moment? What feels like the next best step in this moment? And then specifically thinking about what would I like to note so that I can reduce this happening as often? Because the reality is that like if it's happening now, it may happen again. And so we can interrupt the pattern and think about ways to shift. So we'll come to that next. Just the idea of responding rather than reacting. A reaction isn't a reflexive thing. A response, we're actually choosing how we go. So off to the next slide. And then we're almost done here. So here were just a few thoughts that I wanted to offer. Again, compost them if they don't land for you. But I think validating for folks, especially when patients have 8 more issues after we've figured out the vaccination plan, to name that it's important and to use that as an explanation for why we're not going to jump into it at the end of a session or an encounter. So saying like, this is important. And I need to be honest with you that I don't know that I can give it my best in this moment. And I know it's annoying for you to have to come back. But for now, I think we'll need to sort of find a time to give that the time that it needs. I think often it's hard to fight with that, right? And we can also say, and I'm running an hour behind, or like, and I've got other things going on. So for now, I think it makes the most sense for us to sort of find a way to address that in a way that feels a bit more complete. The other piece is who, where, and what else is possible. So knowing that there can be other resources. I just want to highlight that the how of that really makes a difference. So our skillfulness in storytelling about other resources can go a long way, so that people feel more convinced. So just thinking about the research that shows that if a patient thinks their physician or prescriber thinks the medicine will work, it will work way better. Same with community resources or connecting to team members. If we sell it well, so to speak, there's a good chance that the person might be more interested or think that it's part of a beautiful care plan, not a sort of punting. And then the last thing is about that D for do, thinking about the next step. So if you're getting a bunch of emails from patients or people have wild expectations, thinking about what you'd like your approach to be, and then coming up with a plan to communicate it and roll it out, which takes work up front, though in the long run can help a lot in terms of being really transparent about what's possible. What I would say is if you're coming up with like an email communication strategy or whatever it might be, before you publicize it or share it, to maybe share it with a colleague, chat about options, kind of slow the process down a bit to make sure it feels really settled and clear. And then have a plan to roll it out in a way that feels really good, that honors your time and the way that you want to practice. Because again, we get to choose how we practice, even though it sometimes feels like it's coming at us. Okay. So 2 resources, next slide. We're kind of out of time. I wonder if we can look at the 2 resources and come back to this very briefly. And maybe this could get shared later. So if we go to the next slide, Peer Connect is available. It's totally funded and accredited. So if you wanted to connect with a family physician colleague who has special expertise in working with people with mental illness, substance misuse, and chronic pain, you can meet one-to-one and come up with some goals or strategies. If you're finding it really challenging to address sort of expectations from patients, you could connect with somebody and just come up with some approaches together. So just an option, so you don't have to do it alone if you want. The feedback from participants is quite glowing. So if you're interested, this is available to you. And then the next slide, the idea of patient expectations is a whole thing. And so it turns out that the OMA has a series that the coming event is on the 25th about conflict resolution with patients. So if you're interested in getting some more practice or learning more, this is another resource. I found this by Googling OMA patient expectation series, and it came up. So that's an option. I realize we're at 9 a.m. So I will sort of jump back to you for Q&A, and then maybe once we're done, if people want to look at that that self-compassion invitation, that could be helpful too.
Thanks so much, Chase, for reminding us to acknowledge like the work that we do and the challenges it presents. And I like the reframing of managing patient expectations, even reframing that in terms of acknowledging them. And nice to have an ABCD that doesn't have something to do with moles. So I'm looking forward to putting that into practice. And I know in the chat, there's been lots of comments about how it's helpful to hear these thoughts and tips from you. We are at 8:59 and recognizing everybody's time. I'm going to just turn to our last few slides, and then we'll come back to do a little bit of Q&A for those that are able to stay on.
Okay, I will take these and I'll try to be quick. Just a couple of reminders. There's an osteoporosis fracture prevention workshop coming up. Registration is now open and the session launches on October 30th. Next slide. And wanted to just remind everyone about the Practical Evidence for Informed Practice Conference coming up in mid-October. It's a hybrid event. Some really great topics that you can see listed on the slide, and I believe registration is also open now. Next slide. Okay, and just to remind you again about OCFP supports for mental health, addictions, and chronic pain. You'll see a couple of topics on the slide for the community of practice, including ADHD and technology AI. And Dr. McMurren spoke about our Peer Connect mentorship program, where you can receive tailored support to help manage patients in your practice.
Great, and just a reminder that these sessions obviously are part of a series and you can look up any of them or review them online. Next slide, please. And then also they're made pro-accredited. And next slide, please. So just in terms of, we have a session coming up on September 20th, and actually the first question I see in my most upvotes is about how there's a lot of pneumonia, it seems, out there, and younger people with prolonged cough and fever, which unfortunately won't have time to address today because I feel like that's a whole other topic, but I think we do have PEDS ID coming at our next session in a couple of weeks, so hopefully we'll have a lot of time to chat about it then. And next slide, I think that's the end of our slides. So I know some of you will have to jump off for clinic, and I hope your Fridays go well. For those of you that have a little bit more time, we'll maybe do a few more questions and go from there. So I might just jump back to you, Dan, in terms of, there was a question about if somebody's had Pneumovax 23 at age 65, can they get free Prevnar 20?
Yeah, so at this time, if they've received all of the recommended pneumococcal vaccines in the previous schedule, there isn't an additional catch-up that's being publicly funded. We're hoping that that's something that can be put in place in the following year, but there wasn't ability to purchase basically enough supply this year to catch up everybody who's already gotten a Pneumovax and Prevnar 13. So not yet. They can still purchase it privately this time, but more to come in the future on whether we can get that publicly funded.
Okay. Great. And a couple of questions around communication strategies. And so one of them around, will there be patient and parent information available in different languages for counseling patients around some of these new vaccines and vaccine changes? I don't know if you're aware if there is, Dan.
Yeah, I mean, everything is absolutely available in English and French right now. And I know that many of the other resources coming out from places like PCMCH or SOGC, for example, are going to be in multiple languages. So, be aware those are coming. I don't know if we put links in the chat, but some things are posted already. CEP just posted their whole RSV toolkit is already available. So I encourage people to start looking. In terms of communications like to the public, there'll be kind of more announcements coming up and news releases in the near future about the respiratory season as a whole, including what's going to happen with RSV. So hopefully that's something people are aware of. Local public health, we always encourage lots of social media from our local public health units. And so I'm sure they'll all be doing that soon as well. And then, those patient handouts, again, PCMCH has like a wonderful patient handout that you can have in your offices and be given everywhere. So encourage all of those.
Great, thanks for clarifying that. And actually, I think you spoke to, there was a question about the communication strategy for patients regarding vaccine changes. Sounds like it's going to be coming through a bunch of different routes, hopefully in the next few weeks or month.
Yeah.
Excellent. A question, if a baby already had RSV hospitalized, is vaccine given at some time later or they don't need it? I guess they're asking if a baby has had RSV, would you still give the vaccine?
Yeah, that's a great question. So, I mean, if they currently have RSV infection, we would wait and not be giving them it right away. Like if they're currently fighting off it, you get interference with the antibodies and there can be issues with it. They can still receive it afterwards, even if they have had confirmed RSV infection. And we do see potentially additional benefit in those groups. RSV infection doesn't give like a super robust immune response necessarily. The main thing is that as we get older, our reaction to it gets much less and it's less severe. So that's why we see, 2-year-olds who aren't high risk, we're not concerned so much about it.
Excellent. On different note, I'm going to jump you over to COVID vaccines. Is there a recommendation that healthcare workers should get COVID vaccine this autumn?
Yep, healthcare workers remain recommended to get COVID and flu vaccines. Much higher risk to contract it just because you're contacting patients all the time, even if you're not individually at higher risk for severe outcomes. But both to protect yourself and then patients, we recommend both flu and COVID vaccines for all healthcare workers.
Excellent. In terms of thinking about the RSV vaccines, in terms of the rollout to primary care offices, there's a couple of questions that came in about how we would access it in our clinics. Will it need to be ordered, or it will come to our office similar to the flu vaccine?
Yeah, it'll be ordered same as you would for your routine childhood vaccines. So ordering through your local public health unit as soon as it becomes available. Public health units will let people know when product is there essentially, but it should be in terms of the Beyfortus around mid to late October.
Okay, and in terms of ordering vaccines, similarly for Prevnar 20, is this something that we would be ordering special order to have that come to our office, or how does that work?
So in terms of whether it comes to your office or you pick it up, that's health unit dependent. I think most health units, you have to go pick it up from them at this point. But yeah, it's ordered through the same way as you would have done for any of their vaccines. So you order through your public health unit, and then whatever process they have in place that's how you'd be receiving.
Excellent. And in terms of the Beyfortus, are midwives authorized to administer it? We're just wondering, infants born that are delivered at home often don't see us until they're about 2 months old.
Yeah, so unfortunately this year, no, it's not in the scope of practice for midwives to administer Beyfortus. They can administer Abrysvo to pregnant individuals, but not Beyfortus yet. So midwives should be making local partnerships with primary care hospitals or others to ensure that those infants born under midwifery care in a birthing center have access quickly.
Okay, and a question, is there a difference between the infant RSV vaccine and the adult one?
Yes, so the infant RSV product, Beyfortus, is not a vaccine. It's a monoclonal antibody, so it's providing passive immunity. I mentioned it's more effective from what we've seen, 20 to 30% more effective at preventing medically attended RSV infection. The vaccine is a regular active vaccine that's given to the mother, but the immunity for the infant is still passive because it's maternal antibodies that are being passed down to the infant. So very different products in terms of how they're functioning and how they're administered.
Right, and I think because Beyfortus is new, there's also a question here about, like, in terms of how long it's been on the market. Has it been on for a long time? How do we sort of discuss vaccine safety and efficacy with parents?
Yeah, so it was used broadly last year. It wasn't available in Canada last year, unfortunately, but it was used in the US and throughout Europe. So like literally millions and millions of kids got doses last year. We have really good data coming out from those jurisdictions in terms of safety and efficacy of the product. So it is very effective. In regions where they had really high uptake, they saw like a 90% reduction in RSV hospitalizations. So that's huge. And there was no new safety signal identified different than the trials, just, even amongst the millions of kids who received it last year. So it's a very, very safe product.
Great, and I think actually, because we did talk about RSV back in July, if people wanted to look back at that session, I think you had a great slide showing the decrease in RSV in the countries where they had been vaccinating or using that product, not vaccinating the Beyfortus product. So something people could look back to if they wanted to get more information again about that. Turning just to pertussis, there's a question about, do we have data on how long Tdap works for? Can we recommend a booster even if they've had it as an adult once? Or should we be giving it ever at less than 10 years?
Yeah, I mean, I think, I had this slide about the risk in different age groups and in terms of what we're actually seeing and where it spreads. So the pertussis portion of Tdap does wane relatively quickly compared to some of the other ones. So we often start seeing waning immunity, 5 to 6 years afterwards, which is part of why even in that, 5 to 9 age group, we start to see a potential increase. It's not just missed doses, but there's also some waning. At this time, the publicly funded program is what it is, and I can't recommend outside of the publicly funded program, or that it would be covered in that case, but we do start to see waning. And so people who are higher risk, it may be worth a discussion, particularly if they're around lots of infants, pregnant individuals, that sort of thing.
Excellent. Turning from pertussis to Prevnar, and I think we had chatted about this and put up a slide about it, but can you clarify who should receive Prevnar 13 versus Prevnar 20? I think we now know it's got easier for us.
It has easier. So no one should be receiving 13 anymore. 15 is the product that we recommended for any of the low-risk infants. So the routine childhood program pneumococcal vaccine should be the PCV 13 product that's given. Everyone else outside of just the routine childhood, so high-risk children, high-risk adults, older adults, they should all be receiving the Prevnar 20 product.
Great. Nice to keep it simple. And I'm sorry, I'm going to jump you back onto pertussis again, because there was a question, just because we are seeing pertussis in the younger infants, do we know whether these are in infants where the mom didn't receive the pertussis vaccine? Do we have any information about why that might still be happening despite wider vaccination rates?
Yeah, so unfortunately, our vaccine uptake in pregnant individuals is not good for Tdap and for many of the vaccines. So pregnant individuals are often very health conscientious and careful about what they might be getting. We generally see lower uptake of vaccines in that patient population. And so our Tdap uptake is low. We don't have great numbers, obviously, because we don't have a registry to identify. But, you know, the studies that have looked at it show that it might be maybe 30 to 50%. So there's an awful lot of pregnant individuals who are not getting a pertussis vaccine, and that's part of the issue. And that probably is the main thing that we could do to provide additional protection to newborns, would be just getting uptake in pregnant individuals higher.
Excellent. And I think we'll make this the last question, just so that people can get off to the rest of their day. In terms of the RSV public program, expansion to the general public over 60, is this something that we're expecting might happen in the future? I think you had mentioned that it might expand at some point, but not this year.
Yeah, so it probably won't be over 60. So NACI recommendations are for over 75. So at this point in time, like this year, it's as I described the program. It's something that's being looked at, whether next year it could be an expanded program to cover more of those recommended populations or NACI. So, you know, that would be something to come next year. There's more details about it.
Excellent. Thanks very much. And I would like to thank you for speaking today, as well as our other panelists, Dr. Darrell Tam and Dr. Chase McMurren. It was really a pleasure to have all three of you on, and thank you for answering the many questions and for presenting today. And we have another session in 2 weeks, so look forward to seeing people back then. Dr. Damji will be back in the moderator chair, and I hope everybody has a wonderful rest of the day and weekend.